I was asked to move up this lecture by an hour so that you guys didn't have to like wait an hour and have nothing. No problem. So I'm Altomare. This is kind of a weird pharmacology lecture. It's a mash of a bunch of things. So endocrine therapy, anti-HER2 therapy, and I had to stick in bone-sparing agents and bone health in this because there was no other place for it. Capricorn was supposed to give this talk and has given this talk in the past. He couldn't do it. Then Will Gwynn was supposed to do it, and he has the boards, so I'm in. And I kind of changed the format. I'd be much more informal. And I'm going to ask you guys questions, not obviously to test you, but just because I think it'll be more interesting that way. And most everybody knows this stuff already. So this will sort of be more of a review than information, and hopefully with some clinical pearls. So I'm going to talk about pharmacology of endocrine therapy, anti-HER2 therapy, and then the pharmacology of the bone-sparing agents. I'm going to ask you guys what you know about the side effects of these agents. And then, this is not really a clinical lecture, but I'm going to show pivotal trials for each of these agents that I think you guys should know, or at least have name recognition of the study. So we're not going to go into the clinical data a lot, but just to get an idea of if you know what trial led to the FDA approval or a major indication for each of these therapies. Okay. So I didn't have the ASHSAT book, so I had to pick these questions off of the internet, and they're not the greatest. So here's the first question. In regard to potential effects of tamoxifen and raloxifene, which of the following is true? Tamoxifen is a bone strengthening agent, but tamoxifen is not. Both increase the risk of endometrial cancer. Both decrease the risk of developing a future breast cancer. Or tamoxifen increases hot flashes and raloxifene doesn't. Which is so true. So tamoxifen does have bone strengthening properties. It's not marketed as a bone strengthening agent, but it does increase bone mineral density. The answer is C. So tamoxifen, obviously you use it to reduce the risk of developing a future breast cancer, and raloxifene as well. I'll show you the trial for that. Raloxifene is something that is really used in practice, but is on the boards. There was a question about raloxifene on my boards, so that's why I picked this question, and I'll show you the raloxifene data. The next question, this question sucks, but this is a really good example of the kind of questions that are on the board. So the boards will not ask you specific regimens per se, but they will ask you modalities of treatment. So a 9-year-old person found a 2-centimeter breast mass on self-exam confirmed by mammogram. Biopsy shows a well-differentiated ER-positive, PR-positive, HER2 negative invasive ductal cancer. Axillary exam is negative. What would you do? Neoadjuvant treatment, rectomy, sentinel lymph node biopsy and radiation, MRI, or mastectomy, lymph biopsy and radiation. Yeah, exactly. So they're going to say neoadjuvant hormonal therapy or neoadjuvant, they're going to tell you what regimen that you're using for neoadjuvant treatment. They would just say neoadjuvant chemotherapy. All right. So starting with endocrine therapies. So tamoxifen, obviously number one. So tamoxifen is a selective estrogen receptor modulator. It is a competitive estrogen agonist. So it competes with estrogen to bind to the receptor in breast tissue. It induces a conformational change in the receptor, which then has downstream effects of inhibiting RNA transcription of estrogen-dependent genes. And then by that mechanism, obviously suppresses the growth of tumors that are dependent on estrogen signaling and prevents division in the tumor tissue. So stupid pharmacology stuff. Half-life is 7 to 14 hours, so it's a once-a-day, daily oral dosing. It is metabolized by cytochrome P450. So what are the indications for tamoxifen? What do you use it for?
Adjuvant therapy.
Yes.
ER-positive breast cancer, metastatic, first-line metastatic, ER-PR, and then prevention of high-risk breast cancer.
Perfect. 100% perfect, and in order, actually. So treatment breast cancer. Oh, you did? Adjuvant and metastatic, Oh, DCIS. So DCIS after radiation, and then to reduce the risk of developing invasive breast cancer, and then to primary prevention for patients with high risk by the Gale model. So exactly. Can use tamoxifen in pre- and postmenopausal women. What are the toxicities that you tell patients about tamoxifen? Hashes, yes. Yes, endometrial cancer.
Thrombosis.
Blood clots, absolutely. So those are basically the big three. Another one that I tell patients, cataract. Yes? Well, yes, cataract. So you have an annual eye exam, so you got it. So we did the hot flashes. Also, women who are menstruating will probably lose their period or get irregular periods. Vaginal irritation and dryness is a big one that we don't talk about enough. You do see some GI toxicities. The big one is endometrial hyperplasia and early stage endometrial cancer. The number that I quote, and this is from the largest randomized trial of extended treatment, is 1 in 500. 1 in 500 patients will get endometrial hyperplasia, or usually early stage endometrial cancer, not advanced stage, and then also endometriosis and uterine fibroids. The risk of VTE is 3 times the average risk for pulmonary embolism, 1.5 times the risk for DVT, and 1.5 times the risk for CVD. So you have to get annual eye exams. So this is the basic meta-analysis of several trials, and this was published in the Lancet. Early breast cancer trial is collaborative group, representing 30,000 women treated with tamoxifen, and this led to the numbers that we quote to patients, which is in the first sentence, a 50% relative risk reduction at 5 years of decreased incidence of developing another breast cancer or a breast cancer recurrence. So 50% reduced chance with 5 years of therapy. But have, in the third bullet point, a almost 50% chance of developing a new contralateral breast cancer on the other side. So that's why we use tamoxifen. It cuts down the chances of the cancer coming back, developing a new breast cancer by 50%. So that's with 5 years of treatment. And you guys know that last year, San Antonio Breast Cancer Conference, they showed the data for the use of extended adjuvant treatment for tamoxifen. What was the name of that trial? Atlas trial. Yep. So here's data from the Atlas trial. And as you can see, and I don't know, I need a pointer. Okay. So you can see an increased reduction of 3% for recurrence. And what really was important was absolute additional 3% in mortality for cancer, breast cancer specific mortality, for continuing tamoxifen for an additional 5 years past the first 5 years. Another interesting thing is that this benefit was not seen at 10 years. So 0 to 5, and the study was started at 5. So 5 to 10 is actually the same as placebo, but the improvement and the separation happens from year 10 to 15. So it's really those really late recurrences that you see 12 to 15 years after the initial breast cancer in hormone-positive disease where you get this benefit. So, trial. Also did not see the rate of development of endometrial cancer was actually the same, and also DVT. So the risks are not cumulative over the following 5 years of therapy. And I looked at this. I didn't show the plot, but the benefit was equal for stage 1, stage 2, and stage 3 breast cancer patients. So I thought that was interesting because you still see benefit even if it's just a stage 1 tumor. Okay, so I wanted to mention this. For patients, so we have, based on genes, different ways, different endogenous ability to metabolize via the CYP2D6 pathway. So those of us who are extensive metabolizers will have more metabolism of tamoxifen and actually get better benefits than the patients that are poor metabolizers by their own genes. And so this was a big when I was a fellow, looking at the different genetic polymorphisms. There's no good test to do this, but you should just be aware that the data here exists, that patients that are poor metabolizers will have less benefit from tamoxifen. So if you are concurrently taking drugs that will interfere with metabolism, like the SSRIs, you would actually potentially get less of benefit from taking tamoxifen. So the big ones, the big drugs that do this are the SSRIs. And so venlafaxine has the least inhibition of this pathway, and therefore, if a patient needs to be on an SSRI and they're on tamoxifen, we recommend venlafaxine or Effexor as opposed to Paxil or all the others. Okay, so moving on to raloxifene, which probably this will be the only time that you hear about raloxifene. So I'm including it because it's on the boards. Raloxifene is also a SERM, so it works in the same way as tamoxifen. It is indicated not for the adjuvant treatment of breast cancer, not for the metastatic treatment of breast cancer. It's indicated for patients who are at high risk of developing breast cancer model to reduce the risk of developing breast cancer, not when patients have breast cancer. When you have breast cancer, you're going to use tamoxifen to get the benefit. But raloxifene you can use in postmenopausal women who are at high risk, and then also it is a treatment of osteoporosis. The brand name of this is Avista, if you've ever heard of Avista. Pharmacology is the same as tamoxifen. It actually has a tropism to bone, so it has more bone-building effects than tamoxifen. Toxicities are the same as tamoxifen, except it has less urine cancer, so still a risk, but less cataracts, less thrombosis risk, so still risk, but less. So the major pivotal trial to lead this indication for raloxifene, as you guys know, is called the STAR trial. So the STAR trial was presented at the plenary session of ASCO when I was a second-year fellow. This is a trial. It was postmenopausal women that had a high score by Gale model for developing breast cancer. So high risk of developing breast cancer. These patients were randomized to raloxifene versus tamoxifen, and there was no difference in development of invasive breast cancer. Basically, raloxifene is equivalent to tamoxifen, preventing the development of invasive breast cancer with fewer side effects. So fewer cancers, fewer thrombosis, and less cataracts. So that's what the indication is. So it's safer to use than tamoxifen if you're going to do primary prevention. So that's a question on my boards. So now moving on to aromatase inhibitors. So aromatase inhibitors were...
Why is it with all this like side effects and...
Why is it not used? I don't know. So it's really in the realm of, I guess, internal medicine. We see patients that have DCIS, so we use tamoxifen. We see patients that have invasive breast cancer, so it's possible that in primary care, Avista is used often. I don't see women coming in. It's still available and it does work. I don't see tamoxifen being used as primary prevention. So yeah, I'm not sure why it really caught on. And even as a treatment for osteoporosis, so we're seeing a lot more reclass, but reclass have the benefit of prevention. So yeah. So aromatase inhibitors actually inhibit the enzyme aromatase, converts androgens to estrogens. So, you give an aromatase inhibitor and it blocks the development of estrogen as opposed to the SERMs, tamoxifen and raloxifene, which actually bind to the estrogen receptor. So aromatase inhibitors are actually blocking the production of the hormone. So here are all of them, and there are 3 that are commercially available. There's exemestane, which is aromasin, that is the steroidal that is on the market, and letrozole from Mara, anastrozole or Arimidex, and these are non-steroidal. There are subtle differences in toxicity profile among these 3. We do not have any head-to-head trials showing which of these is better than the other, probably none are, and we also have no data on whether a steroidal works better or worse than the non-steroidals. So basically, the indications are subtly different. You sort of use them interchangeably, and if you have a bad toxicity profile with one, you can switch to another. So here we have the ovary making the major supply of estrogen, which can drive a hormone-positive breast cancer, right? The growth of it. When you use tamoxifen, you're blocking that. In menopausal women, you have no ovarian production of hormones, but you still have estrogen production in other tissues. The adrenal gland, fat, bone, muscle, and brain all will produce estrogen. When you have a menopausal woman, aromatase inhibitor cannot possibly block all of the estrogen that is produced by the ovary. So it gives a premenopausal woman an aromatase inhibitor, blocks some of it, but the feedback mechanism is still intact, and the ovaries will actually upregulate the production of estrogen. So by using an aromatase inhibitor in premenopausal women, you'll actually increase growth of breast cancer. That's why you can never give a menopausal woman an aromatase inhibitor. And in fact, the recommendations are that people have to be perimenopausal for 2 years before you actually can go ahead and be safe to use an aromatase inhibitor. So these are highly bioavailable. Again, the same CYP3A4 metabolism. What about side effects of aromatase inhibitors? Yes, joint pain. Absolutely. One. Increased vascular diseases, yes. Both, exactly. So all of those we tell patients. So in bold what I discussed with patients. Flashes, also irritation is really huge for patients, also under-recognized. Menopausal vaginal bleeding, loss of bone mineral density. There is not the increase in endometrial cancer, so the vaginal bleeding still should be checked out, but you don't have to worry that it's going to be uterine cancer, usually. Arthralgias and myalgias is huge. There is some data to show that if patients develop these arthralgias and myalgias, they actually have improved efficacy in terms of reduced recurrence of breast cancer, so you can tell patients that, at least that means that the medication is potentially working. Abdominal pain, constipation, nausea, and vomiting. Some psych effects is thrombosis, so the cardiovascular effects that you mentioned, but then also CVA. And so you tell them about this, but the risk is much less than with tamoxifen. Okay. So the indications for aromatase inhibitors very similar to tamoxifen. Adjuvant, without the DCIS, so we don't have the data from the trial yet to DCIS. Really for adjuvant treatment, obviously only postmenopausal women, and then metastatic treatment, extended adjuvant treatment. So there's the 5 years of adjuvant and then extended adjuvant after 5 years, either tamoxifen or an aromatase inhibitor. Advanced cancer. And then exemestane has the indication to be used in combination with everolimus in refractory breast cancer, and that's from the Bolero trial. I'm not going to go into that data. So those are all the indications for basically all of the AIs grouped together. There's tons of data that I could show. This is sort of a summary of the same main trials lead to the approval in the adjuvant setting. So the ATTACK trial with anastrozole, and the name should sound familiar to you. N17 trial was for letrozole, and then the IS trial was for exemestane. So all randomized against tamoxifen in postmenopausal patients with early-stage breast cancer. So tamoxifen in yellow versus their 5 years of anastrozole or the extended adjuvant, and the primary author for this is Paul Goss. So additional 5 years past the first of tamoxifen with letrozole, and then this was the switch one, which was 2 to 3 years, and then another 2 to 3 years. And each of these studies show an absolute difference of approximately 3% at 5 years or beyond versus tamoxifen. So that's the benefit that you're getting in absolute terms. In relative terms, it's obviously much higher. So to be familiar with the names of those studies. What else do I have about aromatase inhibitors? That's it.
That's 3% of disease recurrence.
That's 3% in disease recurrence. 3 to 5% in disease recurrence, and there is an overall survival benefit of I think 1 to 2% on tamoxifen. So Tamoxifen reduces the risk by 50%, right? So let's say that you have a patient with stage 2 hormone receptor positive breast cancer with no nodes. So the risk of recurrence is going to be 20%, right? Tamoxifen will reduce that by half, so down to 10%, and then you get another 3%, so down to 7%. And obviously, it's more if the relative risk is greater, if they have a stage 3C breast cancer. Okay, so fulvestrant. Fulvestrant is the last hormonal therapy that I'm going to talk about. Fulvestrant is an anti-estrogen. Are you guys familiar with fulvestrant? So it is a competitive estrogen receptor antagonist. It downregulates the estrogen receptor. So it binds, and instead of competing with the function of estrogen, it just downregulates the receptor by triggering degradation. It's indicated for refractory metastatic disease in menopausal women, progression after tamoxifen or an AI. This is an IM injection. So it's an injection, it's protein bound, it's by the liver. And there's been a lot of recent studies to change the way we dose this. So it was less effective when we were dosing it this way. This is basically known as double dose. You're giving it's a 250 milligram injection, and you actually give 2 of these. So you give 500 milligrams day 1 and 14, so every 2 weeks the first month and monthly. And that is known as double dose fulvestrant, which actually has positive data as per the confirmed trial, which is different than the way we used to dose it. We used to dose it half, and it really wasn't working that well. The side effects of this are basically the same as aromatase inhibitors: no vomiting, constipation, aralgias, headache, back pain, bone pain, the ubiquitous hot flashes. And also, since it's an injection, you get inflammation and pain at the site of the injection. So the data for fulvestrant is very varied, and there are some studies positive for the double dose against just aromatase inhibitor, that the double dose fulvestrant works better than an aromatase inhibitor. There are positive studies to show that fulvestrant double dose in combination with an aromatase inhibitor is better than an aromatase inhibitor alone. And we sometimes do that in postmenopausal metastatic patients. You can add fulvestrant to the AI and get a little bit more bang if you want to get people through sequential hormonal therapy. But there are also negative studies. So there are positive studies for the combination and negative studies for the combination. So it depends. There's no standard of care, and it really depends on what your practice is. If you want to try to use and add fulvestrant to an AI in a patient with metastatic breast cancer, or if you don't believe that that's effective. And that will not be on the boards because we still don't know. You know, there's not a randomized study to show clear benefit. Okay, so moving on to anti-HER2 therapies. So back to this fellow, we did not have any anti-HER2 therapies available. They were all still in clinical trials. And so really just knew that patients with HER2 overexpressing disease did terrible. No way of treating these patients differently. So this is the data to show that with regular chemotherapy and anti-HER2 agents, you see that the median survival for all comers is only 4 years. So even people stage 1 through stage 4, women with HER2 overexpressing disease on average 4 years, and if they had metastatic disease, they lived about a year. Obviously, we can do much better with all therapies in sequence. So this is straight out of Kim Black or Neil Spector's publication from 2009, the JCO. Although the exact mechanisms by which trastuzumab exerts its anti-tumor activity is unknown, several possibilities have been proposed. So Neil Spector admits that we don't really exactly know how Herceptin works. There is a direct cytotoxic effect via antibody-dependent cellular cytotoxicity. So Herceptin triggers that, but then also by binding to and blocking the action of HER2 can meet all of these downstream effects of inhibition of signal transduction, inhibition of tumor angiogenesis, inhibition of DNA damage and repair, and all of these different key pathways, mTOR, AKT, the MEK pathway, are all implicated in the downstream effects of ERB2 signaling. You guys probably know this much better than I do because of all that work that you're involved in. So that's the mechanism of action of trastuzumab, which is not still clearly known. Obviously, it's a monoclonal antibody targeting HER2. It's an IV drug. You give either weekly or every 3 weeks, and you do have to give a loading dose the first time that you use it, or after a break. When you restart it, you have to give a loading dose. Trastuzumab is going off patent now. And so you start seeing data for a new formulation, which is on patent and is able to be administered sub-Q. And so already studies showing that the sub-Q formula is preferred by patients and much better quality of life, so that they can continue to administer this drug on patent with the associated with that. So sub-Q form is coming out. Toxicities that you have to talk to patients about trastuzumab. Yeah, cardiac. So that's actually basically it. So the incidence of cardiomyopathy is actually 2 to 5% for 3 to 4 cardiomyopathy. If you administer trastuzumab together with an anthracycline, not in sequence, but together, then the incidence is 20%. So that's why we don't use azithromycin and trastuzumab together, but you can give it sequentially, where CHF incidence still goes back down to the 2 to 5%. So the recommendations: you're supposed to check the ejection fraction prior to and then during treatment. The EF is poor, you can consider not using the drug. The package insert says to monitor every 3 months, but you can also do it, based on new symptoms. Not everybody checks echoes every 3 months in their patients on Herceptin. If the ejection fraction goes down, you actually stop the drug, hold it in a month, recheck, and 50% of patients recover their cardiac function, and then you can restart trastuzumab and not have additional cardiomyopathy. So you can do that if you want. The initial recommendations are, after stopping trastuzumab, you're supposed to continue to check echoes every 6 months, and patients develop heart failure, treat medically. The only other toxicity is infusion reactions, which people can get myalgias and aches and pains. But, very rarely, and I've never seen this in my life, you can develop interstitial pneumonitis or ARDS.
Quick question.
Yeah.
With the sub-Q formulation, is the reason patients like it better just because it's
just sub-Q? Exactly. Not because it has any less of any of this. It's actually exactly the same, but just because it's easier to get a sub-Q injection and not an IV or a port. This actually does happen. So concurrent administration with chemotherapy, and especially the taxanes, will worsen the neutropenia that you normally see. Okay. So indications for trastuzumab. You guys. HER2 positive, obviously. Combination with
containing chemotherapy.
So alone or in combination. So these are the combinations. You give this is data for a lot of different combinations. This is what's in the label. So C, and you have to follow it with TH. So ATH, right? You can't give AC with the trastuzumab because of the cardiac toxicity. AC followed by TH. So Taxol, carboplatin, and trastuzumab, or as a single agent. So that's adjuvant breast for metastatic, first line in combination, or as a single agent. And then I just gastric in here. So you know that it's also approved for gastric in patients for EG junction or gastric adenocarcinoma, HER2 overexpressing, and that is in combination with capecitabine and cisplatin. So obviously, tons and tons of studies with Herceptin. These are the major adjuvant trials. So major adjuvant trials were N9831, and that was what gave positive data for the was sequential versus combination. And so that's what gets the AC followed by TH, and then completing a year of Herceptin. With all of these were positive studies with very big hazard ratios. And then this one, the BCIRG 006, which led to TCH. Again, with a huge hazard ratio and overall survival benefit. Keep the hazard ratios in mind because this is going to come back when we talk about pertuzumab. So those are just the real big studies for Herceptin, the classic studies, and that led to what's in the label right now. Lapatinib. So lapatinib works differently. Lapatinib is an oral, small molecule dual inhibitor. And what it does is it binds intracellularly and prevents phosphorylation of the HER2 receptor. So trastuzumab is an extracellular monoclonal antibody that binds the receptor. Lapatinib works internally to prevent phosphorylation. Its indications are only in the metastatic setting. So to be used in combination with capecitabine for refractory metastatic breast cancer, HER2 expressing obviously, and then in combination with letrozole if you have triple positive, ER positive, PR positive, HER2 overexpressing. You have to take it on an empty stomach, and it really affects the efficacy of the drug. So you can be very strict about that and tell patients, make sure they take it an hour before or 2 hours after you eat, and it's a bunch of pills at once. It's either 4 if you're taking it with Xeloda, or 5 if you're taking it by itself, 250 milligram tablets. Toxicities of lapatinib.
Cardiac diarrhea.
One more one. Yes, hand, foot, yeah. So, and so I always forget about this, but it's true. You have to monitor LFTs extremely closely. You should actually check them every 2 weeks for the first month. Diarrhea, a lot of people, this is actually dose limiting for them. Fatigue. You can get pretty bad fatigue with this drug. Cardiac, QTc prolongation. So this is kind of pain in the neck. A lot of the targeted agents have this. So you're supposed to check an EEG before you start this drug, and then as per the treating doctor's discretion throughout, and you have to be careful with drugs that are also known to prolong QTc, so some of the anticonvulsants and some of the antibiotics, and then hand-foot syndrome, which is also dose limiting and is seen very often. So some clinical pearls about the use of lapatinib. It's used in the metastatic setting in second line and beyond. In the first line setting, it is not better than trastuzumab. It's actually worse than trastuzumab. So Herceptin is a better drug than lapatinib. That was in the MA31 trial. Combination is known to be active, especially at this institution. Rachel Shaughnessy first presented the data for this, and then Kim Blackwell presented the final analysis and published this. So the combination of trastuzumab plus lapatinib has activity after progression on trastuzumab alone. Data is positive for progression-free survival. I don't know of an overall survival advantage, and this has probably been usurped. Now we have other anti-HER2 therapies. So all this is an active combination, and I think used here quite frequently. In general practice in community medicine, I see a lot of people using this, and it's also not approved to be used. It's not approved to be used in combination like this. So positive data, not FDA approved. Here's study. So you can see that there is an improvement, a doubling of 6-month progression-free survival, but it kind of peters out, and I don't know that this translated into an overall survival benefit. Okay, so newer anti-HER2 therapies, pertuzumab. Pertuzumab is a first-in-class human monoclonal antibody, and actually interferes with homo and heterodimerization of HER2 with GFR, HER3, and HER4. So it works. You guys just had a journal about pertuzumab and the neoadjuvant data. So indications are for first-line metastatic disease in combination with trastuzumab and docetaxel, and then in the neoadjuvant setting with the same drugs. So you only use it with docetaxel and trastuzumab combination. And toxicities are really augmenting the toxicity of Herceptin. So worsened ejection fraction, and the monitoring is exactly the same, and then you get infusion reactions. So here's a pivotal trial, Cleopatra, which I think you guys, did you guys go over that one, or was it the neoadjuvant one that you did? Okay, so here's data for Cleopatra study, really published, and it basically shows improvement of the triple combination of pertuzumab over trastuzumab with docetaxel. But what everybody talks about is the fact that the hazard ratio is nearly the same. So this is the initial, so the hazard ratio is 0.62, which is nearly the same as the initial benefit seen by Herceptin. So Herceptin versus chemo alone has the same hazard ratio as pertuzumab added to Herceptin. So you're really you're adding a lot of expense to the therapy, but you're really getting a major, major benefit equivalent to the life-changing things that Herceptin did when it first was approved. Okay, and then TDM1. So TDM1 is an antibody-drug conjugate. Herceptin is trastuzumab. It is that linked to this really old microtubulin inhibitor cytotoxic drug. It was so toxic when it was tested that it basically led to all crazy toxicity therapy and could never be used. So this linker is what is proprietary from Genentech, and basically the magic, finding a linker that is stable and actually delivers this effectively is what made this antibody-drug conjugate really successful. So it binds, and the cytotoxic drug is delivered intracellularly and actually works as a cytotoxic agent inhibiting microtubule polymerization, just like a regular cytotoxic would. So it is the first of many antibody-drug conjugates that we're going to see. Actually, it's not the first, I guess. Brentuximab vedotin was the first that was FDA approved, but there are tons in development. But yeah, that's true. Yeah, nobody uses it. So Mertine is the actual drug. I don't know how they got from mertansine to emtansine. All approved now for metastatic breast and use single agent. So yet approved in combination with anything else. And only use it for patients that have been exposed to trastuzumab and or a taxane. Or in patients that don't have metastatic, or were treated early stage, not in the metastatic setting, with trastuzumab, but then recurred at a less than a 6-month interval. So toxicities are hepatotoxicity. I've seen this. So the LTs can go up, and you have to hold the drug. This weird entity called nodular regenerative hyperplasia of the liver, which is apparently quite serious, and it manifests similar to portal hypertension. I haven't seen that, but I've seen LFT elevations. Interstitial lung disease, where if you think that's happening, you have to stop the drug permanently. And dyspnea is pretty common. Thrombocytopenia, fatigue, and neuralgias, and then peripheral neuropathy, which I have not seen. So in my opinion, these are the big ones. So the pivotal study for TDM1, yes. So an infusion reaction. So here's the Amelia study, obviously showing a huge benefit and with a very big hazard ratio of 0.61 for this drug by itself in the refractory setting versus lapatinib and Xeloda. And I have used this drug now in community practice and seen like miraculous responses in refractory patients who are just riddled with disease and progressive through Herceptin and lapatinib, and then have a complete radiographic CR on this agent. So it's really to use in the clinic. It's very well tolerated, but there are side effects, and have seen each of those. Like I told you, dyspnea, cough, which can be really bad, and hepatotoxicity. And I find that when you hold and reset the drug and dose reduce, it works just as well as the regular dose. So that's been my experience.
You can dose the TDM1?
Yes. Okay. So moving on to the completely separate topic of bone-sparing agents. So just to talk about what you have to do when you're treating a patient with an aromatase inhibitor, they're going to lose their bone mineral density. So you want to get a DEXA at baseline, and want to check annually if the patients have osteoporosis. If they have osteopenia, or even have a normal bone mineral density, insurance will not pay for more frequently than every 2 years. So it's annually for osteoporosis, every 2 years for other, for as long as they're on the aromatase inhibitor. All patients should be on calcium and vitamin D twice a day. Then, if they have osteopenia, moderate to severe osteoporosis, you can add the bone strengthening agent that you want. Not a standard bone strengthening agent that should be used. There's not algorithms for this. It's basically left up to the treating physician. So there are oral drugs that can be used, like Fosamax. There are monthly drugs like Altomare. There's every 6 months. Daily options like Reclass. The subcutaneous options like Prolia. So you can use whatever you want based on side effect profile and patient compliance. There was a study that had a suggestion that the use of bisphosphonates in the adjuvant setting might actually reduce breast cancer recurrence, and then that was looked at prospectively in the Azure trial. And it was published in the New England Journal as a negative study. So the only negative studies that I know of actually was published in the New England Journal, because many people thought that using bisphosphonates together with AI was going to increase breast cancer recurrence, and it does not at all. So it does in the bones, but it doesn't impact survival from breast cancer. There is a 3-arm SWOG study comparing oral and IV bisphosphonates to see if you really need to give the IV or if the oral is just as good at improving bone mineral density, and we don't have any data from that yet. So you can, as of now, use whichever one you want. So now moving on to bone health in the metastatic setting. So things about bone mets. So these are the cancers where you see bone mets the most often, and prostate cancer is obviously number 1. So when you think of the kind of patients that get bone mets, prostate cancer is the top of the list. But if you look at the data, breast cancer patients get almost as many bone mets as prostate cancer patients. And I'm surprised to see that. I thought this would be way down. Actually, almost as much. And then a third of patients with lung cancer will get bone mets, and then renal cancer. You guys know that the PB kettle, so PKTL, are the cancers that have the most bone mets. P is prostate, B is breast, K is kidney, T is thyroid, L is lung. So patients have bone mets. Ones that get skeletal events, which are basically complications from bone mets, is actually the highest incidences in breast cancer. So even though patients with prostate cancer have the most bone mets, patients with breast cancer get more complications from those bone mets than patients with prostate cancer. The incidence is a little bit higher. And the complications, also known as skeletal-related events, are fractures, pain, spinal cord compression, need for radiation. All those things are what it defines as skeletal-related events. And those can actually be life-changing, maybe life-threatening. You probably wouldn't die, but if you get a spinal cord compression, it's obviously an oncologic emergency, and it will interrupt your cancer therapy and add expense onto, your treatment. Like hip fracture costs $100,000. So if you can prevent getting one of these things or delay developing an SRE, it's a very worthwhile thing to do in patients with metastatic disease. It's actually a quality indicator. So as a cancer provider, my charts are audited. And if I have a patient with breast cancer and they have known bone mets and I'm not giving a bone-sparing agent, I get dinged. And insurance companies are collecting this data to decide who gets better levels of reimbursement. So adding bone-sparing agents, and they don't say which one it has to be, so we have choice, but supportive care is actually a quality measure that is being looked at in our charts. So the options, the first is zoledronic acid or Zometa. It's a bisphosphonate. We don't know how the bisphosphonates work, which is weird. So we know that bisphosphonates will inhibit osteoclastic activity and cause spontaneous apoptosis of the osteoclast, but the exact way that that happens is not really known. That's how all of the bisphosphonates work. And that effect is extremely long-lasting. So the data is actually given once a month. It can also be given once every 3 months. It can be given once every 6 months. And the duration of the apoptosis of the osteoclast is very variable. So it's not really predictable. And that's why the risk of ONJ will continue beyond when the patients are actually getting these medicines. So it's indicated to treat hypercalcemia of malignancy, defined as calcium greater than 12, and cancer. Also, multiple myeloma, all patients with solid tumors, and mets to prevent skeletal-related events. It's an IV infusion over 15 minutes, and you have to dose it according to creatinine clearance because it does cause renal toxicity. So this drug was compared against pamidronate in breast cancer in patients with multiple myeloma. This was published in 2003 in the journal Cancer. And you can see that zoledronic acid was better than pamidronate in reducing skeletal-related events. So this is for breast cancer. That was for multiple myeloma. So that's why we use Zometa preferentially when patients have mets. When you're talking about osteoporosis, you can use the other IV or oral forms of bisphosphonates, but for a patient with bone mets to prevent skeletal-related events, it really has to be IV zolonic acid. Or this drug, which was just recently on the market, a novel rank ligand inhibitor. So humanized monoclonal antibody against rank ligand. Rank ligand is produced by osteoblasts. It states osteoclast-mediated bone resorption. So when you block rank ligand, which is secreted in bony mets, then you block the station of the bone resorption. And then both factors released by the resorption may perpetuate tumor progression and survival. So you may actually, by this mechanism, be blocking tumor and survival as well with this agent over bisphosphonates. It is a monthly subcutaneous injection of 120 milligrams. There is a separate formula that is every 6 months, marketed under a different name. So it's the same drug. Gia is for metastatic bone mets. Prolia is for osteoporosis, and that's just a every 6 month subcutaneous injection. So it's indicated for the prevention of SREs in patients with solid tumors. It was randomized against zolonic acid, and there were 3 separate clinical trials, all conducted at the same time, and then the data was combined for this publication. So there was a breast cancer study, a prostate cancer study, and a study of all other solid tumors and multiple myeloma. So here's the data combined, where you show an improvement in time to the first skeletal-related event by 18% over zolonic acid. So you're laying time to the first bone complication. And here are the number of bone complications, and this is each of the studies individually. So this is breast cancer study, this is the prostate cancer study, and this is the other solid tumor and multiple myeloma study, where you can see an improvement, or actually a reduction in the number of complications, or SREs, over zoledronic acid. It's about 20% in each group, a little bit less in this one. So it works a little bit better than zoledronic acid to prevent the complications from bone mets. Effect profile is a little bit different. So different providers choose based on the ease of administration and all their own cost-benefit analysis, and also the side effect profile, and their belief that this is maybe working a little bit better than this. So both have hypocalcemia. Denosumab has more than zoledronic acid. Both have ONJ, and risk is about 1% per year, maybe a little bit less with Zometa, a little bit more with denosumab. Acute phase reactions are much more with the bisphosphonates. So patients can get chills, they can get muscle aches and pains, they can get rigors. I actually put a patient with prostate cancer in the hospital, and the only person who ever threatened to sue me in 7 years of practice was because of data. So a patient with prostate cancer, and I put him on, he was on docetaxel, and I said, oh, I have to give you this drug to help your bones so that you don't break your hip. And he went into the hospital the next day, and he said, you never told me that I was so bad with that drug, and I almost died, and you're lucky that I don't sue you. And that was just Zometa. So this can be really real, the effects of this, and you don't see it at all with denosumab. This is a monoclonal antibody, so not cleared by the liver or kidneys at all, and therefore has no toxicity, hepatotoxicity, or renal toxicity. You do see the development of renal insufficiency with zoledronic acid on the level of 8% in clinical trials, and you have to redose it. And then there are differences in cost, so Q versus IV, no labs versus checking labs, because you have to check the creatinine, and then the cost per month, even though this is now available, generic, is still $900 plus the infusion costs versus $2,000 a month for denosumab. So you make your own judgment on which one you want to use. And that's it. A lot of disparate stuff in one talk.